Hello friends, so let's have a quick discussion on a very vital topic of PSM, that is cohort study. So cohort study, as you know, it's a prospective study, it's a forward looking study from cause to effect, from risk factor to outcome, exposure to disease, okay. So forward looking study, cause to effect study, exposure to outcome, risk factor to disease, follow up study, incident study. Now see, suppose you have taken 100 smokers selected as study subjects in the year 2020 and you follow them up to the year 2035 and you find that out of 100 smokers 80 develop lung cancer. So this is the cohort study design, forward looking, okay. This is a cohort study design. Now what is the golden rule of any epidemiological study? You should always include a comparison group. What's a comparison group? Comparison group means a non-exposed group, the group which is not exposed to risk factor, okay. For example, the group which is not smoking. So we have to see the group in which it is not smoking, whether they develop lung cancer or not. So what is comparison group? It means non-exposed group, group not exposed to risk factor. So why are we taking this non-smoking group? Because non-smokers can also develop lung cancer. Lung cancer can be caused because of other reasons. Like for example, it can be caused due to air pollution, passive smoking, nickel chromium exposure, asbestos exposure, increased age, male sex. We know that asbestosis can cause a type of lung cancer called mesothelioma. So now coming to the measurement of the strength of association in cohort study. So how do we measure the strength of association? By three ways: relative risk, attributable risk, and population attributable risk. So suppose we have this particular study, we have taken exposed developed lung cancer 70, exposed did not develop lung cancer 6930. So total there were 7,000 subjects. Non-exposed developed lung cancer 3, did not develop lung cancer 2997. Okay, so total is 3,000. So what will be the relative risk? Relative risk definition is incidence among the exposed divided by incidence among non-exposed into, so incidence among the exposed by incidence among non-exposed. So usually we calculate it as a ratio. So here the relative risk is how much? 10. Incidence among smokers is how much? 70. 70 by 7,000. Incidence among non-smokers will be 3 by 3,000. So relative risk is 10. It means that a smoker is likely to develop lung cancer 10 times compared to a non-smoker, okay. Indicates that smokers are 10 times at greater risk of developing lung cancer compared to non-smokers. So relative risk is a direct measure of the strength of association between suspected cause and effect. Now what is the interpretation? Suppose relative risk is more than 1. It means what? The incidence among the exposed is more than the incidence among non-exposed. If it is less than 1, it means the incidence among exposed is less compared to the incidence among non-exposed, which is a negative association. And if it is equal to 1, it means same, neutral, there is no association, okay, which means incidence among exposed is same as the incidence among non-exposed. So more than 1 positive association, less than 1 negative association, equal to 1 no association. Now coming to attributable risk. What is the meaning of the word attributable risk? Okay, so it means the incidence of disease rate among the exposed minus the incidence of disease rate among non-exposed into 100. So it's a percentage. Relative risk was a ratio, this one is a percentage, okay. Now what does the attributable risk say? It says that to what extent that particular risk factor is responsible for the disease, okay. Indicates to what extent the disease under the study can be attributed to the exposure. So here in that previous example we have taken, the attributable risk coming is 90%, which means 90% of lung cancer among the smokers is due to smoking, 10% can be due to other cause. 90% is due to smoking, 10% is due to other cause. We have seen the other cause: air pollution, passive smoking, nickel chromium exposure, asbestosis, male sex, okay. Now what is the population attributable risk? It is the incidence in total population minus the incidence in non-exposed divided by incidence in total into 100, okay. So how does the population attributable risk differ from the attributable risk? Population attributable risk says that if you remove a particular risk factor from the community, how much the disease incidence can be reduced. So by which the disease can be reduced in that population if the suspected factor was eliminated or modified. So look at this question. This is a previous year question. Suppose you are a clinician and a patient comes to you with chest pain. He tells that he is smoker. Which of the following parameters will you use to tell him the harmful effects of smoking on his lung? Okay, so here I will use the parameter relative risk. Why? Because relative risk will give you that, suppose I said relative risk is 7, it means there is 7 times chance of development of lung cancer in a smoker compared to non-smoker, like that. Okay, which parameter is most important for an epidemiologist? Answer is attributable risk. Answer will be attributable risk. And which parameter is most important for a public health manager? See, what does a public health manager do? A public health manager will try to implement a public health program, and his program is based on the fact that if you eliminate a particular risk factor, by how much the disease incidence in the population will be reduced. Okay, so it will be the population attributable risk. Okay, overall, which is the best parameter? Relative risk, because it is giving you a direct indication that if the risk factor is present, or if a person is exposed to that particular risk factor, how much chances of developing a disease or cancer compared to a non-exposed person. Advantage of the cohort study. So cohort study, the most important advantage is that the incidence can be calculated, and we have seen the incidence can be done by relative risk, attributable risk, and the population attributable risk. Okay, so incidence rate of the disease can be calculated, and also we can see if you study the outcome of the exposure to risk factor, like for example outcome of smoking for a considerable amount of years. So apart from lung cancer, other incidents can also occur. Yes or no? For example, smoking, we know it can lead to what? Prostate cancer, urinary bladder cancer, emphysema, chronic bronchitis, like that, COPD. So several other possible outcomes related to the exposure can be studied simultaneously. For example, apart from lung cancer, the association of the smoking with many other conditions like cancer of the esophagus, peptic ulcer, coronary heart disease can be studied. It provides a direct estimate of the relative risk, and since comparison groups are formed before disease develops, certain bias like misclassification of the individuals into exposed and non-exposed groups won't occur. And what are the demerits? Demerits will be, it will take time to complete the study. So it will take a long time to complete the study. It is not suitable to investigate a rare disease, okay, or an uncommon disease. One more thing is that you have to keep a large number of individuals under surveillance for a long time. So you can suffer from attrition. Attrition means loss from your cohort, loss of members from the original cohort, okay. So loss from the original cohort or attrition. Attrition can occur due to migration, loss of interest in the study, self-awareness. The person becomes self-aware that okay, a study is going on between smoking and its outcome, where the possible outcome as told by the epidemiologist is lung cancer. So okay, I will quit smoking from today. So there can be alteration of behavior in the members. Apart from that, there is loss of funding and experienced staff, and also it's an expensive process because you have to follow up for a long time. Cohort study is a follow-up study, right? And what is the maximum allowable attrition in cohort study? It's less than 5%. Okay, thank you.